Bismillahirrahmanirrahim. Oh, ditutup aja ya? Oke. Ih, kok kamu tetap ada, Ci?
Pesan dan hasil untuk pasien-pasien yang sudah kita lakukan operasi tersebut dengan tingkat presisi dari operasi laser ini yang sudah dipreset oleh tim cukup puas ya, cukup memang ini belum terlalu long term ya kita melihat hasilnya, tapi untuk hasilnya sesuai dengan yang kita harapkan.
Kekuatan memotongnya sih baik, bagus. Kalau untuk handpiece-nya baik karena handpiece-nya ini cukup firm, yang lain-lain sih so far bagus ya.
Kita dapat membuka stenosis ini jauh lebih tepat, jauh lebih mudah.
Melakukan operasi pada tumor valikula, di mana tumor tersebut saya inkisisi dengan menggunakan laser, dan untuk bleeding controlnya enak sekali, dan pasca operasinya ternyata jaringannya bagus gitu.
Penggunaan laser sistem cukup membantu dalam praktek, terutama untuk kasus-kasus laryngology yang membutuhkan presisi tinggi. Pengalaman saya pribadi, kurva belajar untuk alat ini relatif cepat, dan hasil visualisasi jaringan juga cukup jelas.
Pada operasi di area hidung, sinus, hingga skull base, tantangan terbesar dokter bukan hanya mengangkat polip atau membersihkan penyakitnya saja. Namun, tantangan terbesarnya adalah bekerja di area yang sangat sempit, bahkan berdekatan dengan struktur-struktur vital seperti orbita, optic nerve, skull base, karotid arteri, bahkan otak. Tidak semua anatomi terlihat jelas. Tidak semua kasus berjalan sesuai anatomi yang dipelajari, apalagi pada refer case. Semakin kompleks anatominya, semakin besar pula kebutuhan seorang dokter untuk mengetahui dengan pasti di mana posisi instrumen yang sedang digunakan. Saat ini, saya ingin mengajak dokter untuk melihat bagaimana sistem navigasi bedah Naviol membantu dokter merencanakan, memandu, dan meningkatkan keamanan tindakan pada berbagai kasus rinologi. Dengan Naviol, presisi bukan lagi sebuah tantangan, melainkan standar baru dalam tindakan bedah THT.
Lima tahunan lebih saya gunakan, alhamdulillah tidak mengalami
Saya dokter Assoc dari Rumah Sakit Jawa Bali Banda Aceh. Nah, saya selama ini memang sudah menggunakan ini monitor scope ini dan juga radio frekuensi yang dari perusahaan ini. Jadi sudah sekitar 5 tahunan lebih saya gunakan, sebenarnya tidak mengaruhkan, dan itu sangat membantu saya dalam baik di rumah sakit maupun di praktek. Dan alhamdulillah kalau ada sesuatu kesulitan atau gambar yang kurang, saya bisa berkomunikasi langsung dengan para petugas perusahaan dengan baik.
Very recommended sekali. Milimeternya itu kecil sekali ya. Jadi untuk bayi bisa, untuk anak-anak bisa, untuk dewasa bisa. Perkenalkan, saya Dr. Ismail-Aini, spesialis T.H.T.B.K.L dari RSUD saya Kabupaten Cianjur. Saat ini saya sudah menggunakan RLFO dari SPI. Dan itu very recommended sekali karena gambarannya sangat jelas dan milimeternya itu kecil sekali ya. Jadi untuk bayi bisa, untuk anak-anak bisa, untuk dewasa bisa. pesan dan hasil untuk pasien-pasien yang sudah kita lakukan operasi tersebut dengan tingkat presisi dari operasi laser ini yang sudah dipreset oleh tim cukup puas ya, cukup memang ini belum terlalu long term ya kita melihat hasilnya, tapi untuk hasilnya sesuai dengan yang kita harapkan.
Kekuatan memotongnya sih bagus. Kalau untuk handpiece-nya baik karena handpiece-nya ini cukup firm, yang lain-lain sih so far bagus ya.
Kita dapat membuka stenosis ini jauh lebih tepat, jauh lebih mudah.
Operasi pada tumor valikula, di mana tumor tersebut saya inkisi dengan menggunakan laser dan untuk bleeding controlnya enak sekali, dan pasca operasinya ternyata jaringannya bagus gitu.
Penggunaan laser Sp.T.H.T.B.K.L membantu dalam praktek, terutama untuk kasus-kasus laryngology yang membutuhkan presisi tinggi. Pengalaman saya pribadi, kurva belajar untuk alat ini relatif singkat dan hasil visualisasi jaringan juga cukup jelas.
Pada operasi di area hidung, sinus, hingga skull base, tantangan terbesar dokter bukan hanya mengangkat polip atau membersihkan penyakitnya saja. Namun, tantangan terbesarnya adalah bekerja di area yang sangat sempit, bahkan berdekatan dengan struktur-struktur vital seperti orbita, optic nerve, skull base, karotid arteri, bahkan otak. Tidak semua anatomi terlihat jelas. Tidak semua kasus berjalan sesuai anatomi yang dipelajari, apalagi pada repair case. Semakin kompleks anatominya, semakin besar pula kebutuhan seorang dokter untuk mengetahui dengan pasti di mana posisi instrumen yang sedang digunakan. Saat ini, saya ingin mengajak dokter untuk melihat bagaimana sistem navigasi bedah Naviol membantu dokter merencanakan, memandu, dan meningkatkan keamanan tindakan pada berbagai kasus rinologi. Dengan Naviol, presisi bukan lagi sebuah tantangan, melainkan standar baru dalam tindakan bedah T.H.T.
Tahun lebih saya mudahkan kemudian tidak mengantar. Saya sudah kuat dari rumah sakit pada Aceh. Nah, saya selama ini memang sudah menggunakan ini melakukan Sp.T.H.T.B.K.L ini dan juga radio frekuensi yang dari perusahaan ini. Jadi sudah sekitar 5 tahun lebih saya mudahkan kemudian tidak mengantar, dan sangat membantu saya dalam baik di rumah sakit maupun di praktek. Dan alhamdulillah kalau ada sesuatu kesulitan atau tentang gambar yang kurang, saya bisa berkomunikasi langsung dengan para petugas perusahaan dengan baik.
Ya, lagi. Ya.
Jumlah ya, sampai jalan.
Very recommended sekali. Indikator itu kecil sekali ya. Jadi untuk bayi bisa, untuk anak-anak bisa, untuk dewasa bisa. Perkenalkan, saya Dr. Sp.T.H.T.B.K.L, spesialis FICS dari RSUD saya Kabupaten Cianjur. Saat ini saya sudah menggunakan Relevo dari SPI. Dan itu very recommended sekali karena gambarannya sangat jelas dan milimeternya itu kecil sekali ya. Jadi untuk bayi bisa, untuk anak-anak bisa, untuk dewasa bisa.
Dan juga ada PIKC dan kan seperti makin kita itu positif, maksudnya tidak saja Jadi maksudnya itu artinya pada saat kita angkat tumornya dan dilakukan pemeriksaan pada mikroskop. Jadi batas dari Subsp.L.F ini itu batas itu masih dengan adanya maksimum mati dengan segala sampai bukti dari tersebut, sehingga hal itu dapat melakukan problem seperti
pesan dan hasil untuk pasien-pasien yang sudah kita lakukan operasi tersebut dengan tingkat presisi dari operasi laser ini yang sudah dipreset oleh tim cukup puas ya, cukup memang ini belum terlalu long term ya kita melihat hasilnya, tapi untuk hasilnya sesuai dengan yang kita harapkan.
Kekuatan memotongnya sih bagus. Kalau untuk handpiece-nya baik karena handpiece-nya ini cukup firm, yang lain-lain sih so far bagus ya.
Kita dapat membuka stenosis ini jauh lebih tepat, jauh lebih mudah.
Melakukan operasi pada tumor valikula, di mana tumor tersebut saya eksisi dengan menggunakan laser dan untuk bleeding controlnya enak sekali, dan pasca operasinya ternyata jaringannya bagus gitu.
Penggunaan laser Sp.T.H.T.B.K.L membantu dalam praktek, terutama untuk kasus-kasus laryngology yang membutuhkan presisi tinggi. Pengalaman saya pribadi, kurva belajar untuk alat ini relatif singkat dan hasil visualisasi jaringan juga cukup jelas.
Pada operasi di area hidung, sinus, hingga skull base, tantangan terbesar dokter bukan hanya mengangkat polip atau membersihkan penyakitnya saja. Namun, tantangan terbesarnya adalah bekerja di area yang sangat sempit, bahkan berdekatan dengan struktur-struktur vital seperti orbita, optic nerve, skull base, karotid arteri, bahkan otak. Tidak semua anatomi terlihat jelas. Tidak semua kasus berjalan sesuai anatomi yang dipelajari, apalagi pada repair case. Semakin kompleks anatominya, semakin besar pula kebutuhan seorang dokter untuk mengetahui dengan pasti di mana posisi instrumen yang sedang digunakan. Saat ini, saya ingin mengajak dokter untuk melihat bagaimana sistem navigasi bedah Naviol membantu dokter merencanakan, memandu, dan meningkatkan keamanan tindakan pada berbagai kasus rinologi. Dengan Naviol, presisi bukan lagi sebuah tantangan, melainkan standar baru dalam tindakan bedah THT.
Lima tahunan lebih saya mudahkan, alhamdulillah tidak mengalami. Saya dokter Assoc dari Rumah Sakit Jawa Ambil Banda Aceh. Nah, saya selama ini memang sudah menggunakan ini melakukan Sp.T.H.T.B.K.L dan juga radio frekuensi yang dari perusahaan ini. Jadi sudah sekitar 5 tahunan lebih saya mudahkan, alhamdulillah tidak mengalami. Dan itu sangat membantu saya dalam baik di rumah sakit maupun di praktek. Dan alhamdulillah kalau ada sesuatu kesulitan atau gambar yang kurang, saya bisa berkomunikasi langsung dengan para petugas perusahaan dengan baik.
Ini kan udah aku sambung. Semua. Terus kan TV-nya juga sebenarnya ada suara, Kak. Harus
Thank you for all doctors. Welcome to today's scientific webinar. Assalamualaikum warahmatullahi wabarakatuh. Good afternoon everyone. Salam sejahtera untuk kita semua. Om Swastiastu, Namo Buddhaya, salam kebajikan. A very warm welcome to our distinguished guests, doctors, and all participants joining us today. We are delighted to have you with us for this scientific webinar hosted by PT Sometech Indonesia. Today, we are pleased to bring together two experienced clinicians from Turkey and Indonesia to share their clinical perspective, experiences, and cases on the use of blue laser in laryngology. Today, we are very pleased to bring you an international scientific webinar entitled Blue Laser in Laryngology, Clinical Experience and Practical Applications. Before we begin, allow me to welcome and acknowledge our distinguished guests. First, we would like to welcome Mr. Moses as Director of PT Sometech Indonesia. We also have Mrs. Maya Sumbi as Sales Manager of PT Sometech Indonesia. And of course, our distinguished international speaker, Association Professor Mehmet Burak MD FEBORL-HNS, Consultant Otorhinolaryngologist and Head and Neck Surgeon from Turkey. Welcome, Professor Mehmet. And our moderator for today's scientific session, Dr. Fauziah Fardizza, Sp.T.H.T.B.K.L, Subspesialis Laryngfaring Konsulen. Selamat datang, Dr. Ezi. We will also like to warmly welcome for all ENT specialists, laryngology specialists, residents, fellows, and all doctors participating in today's webinar. Thank you very much for taking the time to join us this afternoon. As the host from PT Sometech Indonesia, it is truly our pleasure to facilitate today's scientific discussion and bring together our speakers and medical professionals for this session. We hope today's webinar will provide valuable knowledge, clinical insights, and a better understanding of the role of blue laser in laryngology. Before we start our program, let us take a moment to pray according to our respective religions and beliefs. May today's webinar run smoothly and bring valuable knowledge and meaningful clinical insights to all of us. Baik Bapak dan Ibu dokter, marilah kita berdoa. Berdoa dipersilahkan. Berdoa selesai. Thank you very much everyone. Before we move to our main session, allow me to share a few brief housekeeping announcement. First, setelah webinar selesai, Bapak dan Ibu dokter dimohon untuk mengisi vote yang akan muncul pada layar Zoom setelah sesi Q&A. For our international participants, after the Q&A session, please stay until the end of the webinar, as a short voting form will appear on your Zoom screen. We kindly ask everyone to take a moment to complete it. Second, during the discussion and Q&A session, participants who would like to ask a question may use the raise hand feature. Untuk peserta yang ingin bertanya, silahkan menggunakan fitur raise hand dan moderator nantinya akan mempersilahkan beberapa peserta untuk menyampaikan pertanyaannya secara langsung. And the last, e-certificates will be provided to participants who fulfill the attendance requirements. The e-certificates will be shared via WhatsApp by the PIC of each doctor. For further information regarding the e-certificate, please kindly follow the attendance requirements provided by the organizing team. Baik, Bapak dan Ibu dokter sekalian, that covers our housekeeping announcement. So, without further ado, let's move on the first session of today's program. To officially open today's event, we would like to invite the Director of PT Sometech Indonesia to deliver his opening remarks. Mr. Moses, the screen is yours.
Making people healthy and confident through innovative healthcare. I'm Moses, Director of STI. Thank you for joining us at Blue Laser in Laryngology seminar today. We are so happy to invite you, especially the seminar moderator, Dr. Fauziah, Fardizza. And it is our great honor to introduce a special speaker today, Professor Dr. Mehmet Burak Aşık. He is a renowned ENT and head and neck surgery specialist at the Memorial Ankara Hospital in Türkiye, specializing in voice disorders, laryngology, and airway surgery. Thank you very much, Professor Mehmet, for your time and lecture today. We are excited to present our innovative 450 nanometer blue laser system, Sp.T.H.T.B.K.L. It delivers precise tissue cutting, excellent bleeding control, and faster patient recovery. We believe Sp.T.H.T.B.K.L blue laser will be a major paradigm shift for laryngeal surgery in Indonesia, enhancing your practice and delivering better outcomes for your patients. I hope this seminar provides you with valuable insights for your clinical practice. Thank you.
Thank you very much, Mr. Moses, for your warm and inspiring opening remarks. Okay, before we move into our scientific session, we would like to give you a brief introduction to the technology that will be the focus of today's discussion. Blue laser technology has been gaining attention as an advanced laser technology with application in various medical procedures, especially laryngology. To give us a brief introduction and visual overview of the technology, we would like to invite everyone to watch a short blue laser product video from PT Sometech Indonesia. So, for all doctors, please enjoy the video.
pesan-pesan dan hasil untuk pasien-pasien yang sudah kita lakukan operasi tersebut dengan tingkat presisi dari operasi laser ini yang sudah dipreset oleh tim cukup puas ya, cukup memang ini belum terlalu long term ya kita melihat hasilnya, tapi untuk hasilnya sesuai dengan yang kita harapkan.
Kekuatan memotongnya sih bagus. Kalau untuk handpiece-nya baik karena handpiece ini cukup firm. Yang lain-lain sih so far bagus ya.
Kita membuka Sp.T.H.T.B.K.L lebih tepat,
operasi pada tumor valikula, di mana tumor tersebut saya eksisi dengan menggunakan laser dan untuk bleeding controlnya enak sekali, dan pasca operasinya ternyata jaringannya bagus gitu.
Penggunaan laser Sp.T.H.T.B.K.L membantu dalam praktek, terutama untuk kasus-kasus laryngology yang membutuhkan presisi tinggi. Pengalaman saya pribadi, kurva belajar untuk alat ini relatif cepat dan hasil visualisasi jaringan juga cukup jelas.
Thank you. We hope the video has given everyone a brief overview of the blue laser technology that will be further discussed from a clinical perspective in today's session. And now, let's move on to our scientific session. Okay, allow me to introduce our moderator for today's webinar. Our moderator today is Dr. Fauziah Fardizza, Sp.T.H.T.B.K.L, subspecialist laryngopharynx consultant, a consultant in laryngopharyngology at the Department of Otolaryngology, Head and Neck Surgery, Faculty of Medicine, University of Indonesia, RSUPN Dr. Cipto Mangunkusumo. She completed her medical education at Trisakti University in 1989, followed by her specialist training in otolaryngology head and neck surgery at the University of Indonesia in 2001. In 2010, she completed a fellowship in head and neck oncology and voice and laryngopharynx at Seoul National University in Seoul. She was appointed as a consultant in laryngology and pharyngology in 2013 and subsequently completed her doctoral program in medical science at the Faculty of Medicine, University of Indonesia, graduating in 2016. Since 2009, she has been actively involved as a faculty member in the Division of Laryngopharyngology, Department of Otolaryngology, Head and Neck Surgery, Faculty of Medicine, University of Indonesia. She has also held several important professional positions from 2010 to 2022. She served as treasurer of the Indonesian Society of Otolaryngology, Head and Neck Surgery, or P.T.H.T.B.K.L, Greater Jakarta. In 2023, she became the head of CODI Laryngopharyngology Study Group. In 2024, she served as the president of the Asia Pacific Pediatric Association, or APAC, and 2025 as the president of the Asia Pacific Laryngology Association, or APLA. With her extensive academic, clinical, and professional experience in laryngopharyngology, we are honored and very pleased to have Dr. Fauziah Fardizza guiding today's scientific discussion. Dr. Ezi, I'll hand over the session to you.
Thank you, Miss Viola. And good afternoon. Assalamualaikum warahmatullahi wabarakatuh. Good afternoon, everyone, professors, colleagues, and doctors. Welcome for today's webinar from Sometech Indonesia. And it is a pleasure to moderate this session on the use of blue laser in the laryngology. I'm Fauziah Fardizza, you can call me AZ, and the consultant from Laryngopharynx Division of ENT Department, Cipto Mangunkusumo Hospital, Faculty of Medicine, Universitas of Indonesia. Today, we are very pleased to have Professor Mehmet Burak. Am I pronounce you well? Yeah, who has extensive experience in laryngology and laser applications. And today he will be share insight into the role of blue laser technology in laryngology surgery. We have 2 sessions. We'll have the presentation first. It takes about 45 minutes, followed by questions and answer sessions. It's about 15 minutes, and feel free to ask the questions as much as you do, and there is no stupid questions here. And submit your questions by raise hand up feature. And the second sessions will be clinical case video and explanation. It's about 20 minutes. And I'm gonna read the Professor Dr. Mehmet Burak CV. Professor Mehmet Burak is 21 until 27. He's a doctoral from Guhan Military Medical Faculty, Turkey. And 2014, he finished his residency in otolaryngology, head and neck surgery. 2017, he doing the fellowship in Enlargen, Germany. 2019, and he done adult and pediatric airway surgery fellowship in Lausanne, Switzerland. And he do also the FEBORL-HNS in Turkish, both certifies otolaryngology. And since 2023, he practicing in Ankara, Turkey, aerodigestive and laryngeal surgery, and a member of European Laryngology Society and European Union Phoniatrician. And the position now, he is a General Secretary of SKY-BD, Turkish Airway and Laryngology Society, and a jury member of FEBORL-HNS Examination Board. And we welcome you. Please, you have time is yours.
Thank you so much. It's a good afternoon, everyone, dear colleagues and dear chair, Sometech company. It's a absolute honor for me to be here with you in this important and beautiful meeting about laser use in laryngology. If it's okay, I'm gonna start.
Yes, please.
Okay. Thank you so much. We are here to discuss about laser use in laryngology. As all of you know, we are currently using laser for our laryngology cases regularly. Over the past 4 decades, the integration of laser technology into laryngology has fundamentally transformed our surgical philosophy. I'm sorry. Yes. Is it possible? I want to share my slides.
Yeah. Just do the share.
Yes, doctor.
Okay.
Wait a moment.
Yes, Fiona.
Okay.
Okay. I'm sorry. Are you allowed, Fiona? Are you allowed to share my presentation?
Okay, doctor.
We cannot see the paper. Yes.
The moderator of the panel should give me the permission.
Can you share the PPT?
Okay, doctor, you can share screen.
Yes.
Your PowerPoint now.
Okay.
Share?
Yes, of course. Thank you so much. The integration of laser technology is shifting us away from broad tissue excision toward micron precision, organ-preserving microflap techniques, and specialized office-based procedures. However, achieving superior functional and oncological outcomes.
Professor, your PowerPoint is not moving.
Sorry?
You're still in the title.
Yes, of course.
Okay.
Yes, of course.
Sorry.
No problem. Our functional and oncological outcomes requires more than just clinical skills. It demands high technology and understanding technology. We have to understand and use our knowledge to learn about laser, physics, wavelength interactions, delivery modalities, and safety rules. Firstly, we have to start with what is laser. Laser is an acronym for light amplification. I'm sorry. Laser amplification of stimulated emission. Laser amplification by stimulated emission of radiation. Unlike a light bulb, which emits incoherent scattered light across a broad spectrum, a laser is an electro-optical device that generates a highly organized, concentrated beam of electromagnetic energy. Four physical elements define laser light. The most important element is monochromaticity. The light consists of a single pure wavelength corresponding to a specific electromagnetic frequency, and this monochromatic nature allows us to selectively target specific chromophores in human tissue. What is chromophores? What are chromophores? They are water, oxyhemoglobin, or melanin. We use these chromophores to target tissue by cutting or vaporization laser. It's a collimated light, it's a coherent light, and it has high irradiancy. How is this coherent light generated within the laser unit? First, we have pump energy, and we have to make transition to the atoms. Afterwards, when an excited electron is struck by an incoming photon, whose energy matches the transition gap, the electron falls back to a lower energy state. In doing so, it emits a second photon that is identical in wavelength, phase, direction, and polarization to the incident photon. This creates a cascading chain reaction of identical photons. We utilize an optical resonator cavity for light amplification. The laser medium is positioned between two parallel mirrors. One fully reflective mirror at the back and one partially transmissive at the front. Photons bounce back and forth through the medium repeatedly, triggering stimulated emission and amplifying the light beam. Lasers are classified based on their physical state of their active laser medium and their temporal emission patterns. These are solid, liquid, gas, semiconductors, and liquid, like a liquid laser, excimer laser. Excited dimer, as we call it, excimer laser, is same as liquid laser. Regarding temporal emission patterns, how the laser delivers power over the time governs thermal accumulation in delicate laryngeal tissues. We use continuous modes. The laser beam is emitted uninterrupted at a constant power output, while effective for cutting. Continuous exposure increases thermal conduction into adjacent laryngeal tissues. We have pulse mode, we have Q-switch mode, cavity dumped mode, and mudlock mode. The last of three modes is occurring in nanoseconds or picoseconds. The clinical effect of laser depends on key variables. They are spot size, spot area size, power, application time, and irradiancy. When a laser beam strikes laryngeal mucosa, four optical phenomena may occur. These are reflection, transmission, dispersion, and absorption. From a surgical perspective, absorption is the primary driver of tissue vaporization and cutting. When a laser radiation strikes a tissue, the temperature begins to rise. Between 10 Celsius degrees and 45 Celsius degrees, change of proteins may occur. In 50 Celsius degrees, enzyme activity reduces. Mucosal enzyme activity reduces. Between 60 and 99 Celsius degrees, coagulation begins. So, we use laser in laryngeal surgery, and larynx mucosa gives us a reaction, and this reaction changes with the heat, with the temperature of laser light. Above 100 Celsius degrees, vaporization starts. And between 400 Celsius degrees and 500 Celsius degrees, char starts to burn. I'm sorry. We don't like chars. We don't like scars. We don't like debris in laryngeal surgery. So, excessive charring must be avoided as carbon deposits absorb non-specific thermal energy, because this leads intense inflammation, delayed healing, and excessive scarring. Different laser wavelengths interact with specific tissue target elements, as I stated before, known as chromophores. In laryngology, our primary target chromophores are melanin, oxyhemoglobin, and water. Especially, I will mention in my following slides, especially blue lasers are using oxyhemoglobin as a chromophore, and carbon dioxide lasers are using water as a chromophore. Argon laser emits in the green spectrum, absorbed predominantly by oxyhemoglobin. KTP laser, it aligns with the absorption peak of oxyhemoglobin as well. Blue laser, as I said before, uses oxyhemoglobin as a chromophore and emits in the visible in the blue spectrum. For this reason, we call blue laser. For this reason, we call this type of laser as blue laser. ND-YAG laser operating in the near infrared spectrum, and it's poorly absorbed by water. I'm sorry. And finally, carbon dioxide laser, located in the far infrared spectrum, and its absorption in water is extraordinarily high. Its tissue penetration is limited. For this reason, its tissue penetration is limited to a superficial 30 micrometers. To choose the optimal tool for a specific laryngological pathology, we must compare our main surgical modalities across 4 key clinical parameters. These parameters are tissue precision, hemostasis, line of sight need, and in-office feasibility. The carbon dioxide laser offers ultra-high, micron-level surgical precision, followed closely by cold instruments and photoangiolytic lasers. The blue laser is a photoangiolytic laser. Cold instruments provide minimal hemostasis. The carbon dioxide laser reliably seals small mucosal vessels. However, photoangiolytic lasers, the blue lasers, provide superior selective microvasculature hemostasis. For the hemostasis condition, in my practice, in my opinion, for the hemostasis condition, blue laser is much better than carbon dioxide laser. Both carbon dioxide micro manipulators and cold instruments require a strict direct line of sight through the rigid laryngoscope. In contrast, blue laser, the other photoangiolytic lasers, can be delivered via fiber optic laryngoscope, and eliminating this condition eliminates line of sight restriction. We use blue laser or KTP laser within a fiber optic cable, and we use them in office procedures. Neither carbon dioxide laser nor transoral robotic surgery can be performed in outpatient clinical setting. However, photoangiolytic lasers can be passed through the working channel of a fiber optic laryngoscope, and they can be used very easily in office setting. We have 4 types of basic laser tissue interactions. These are photothermal effect, photomechanical effect, photochemical effect, and photoablative effect. The most important effect in these 4 effects are photothermal effects. I would like to highlight the blue laser, which represents a major recent advancement in photoangiolytic laryngological surgeries. Its peak absorption in hemoglobin is approximately 10 times higher than that traditional photoangiolytic lasers. We call them KTP lasers. This high absorption coefficient yields two distinct operational modes within a single device. These modes are photoangiolytic mode and cutting mode. At a non-contact distance, the beam selectively photocoagulates subepithelial microvascular structures, causing involution of vascular lesions like ectasis, polyps, papillomas, varices. In cutting mode, this mode brought into close contact or high power density the blue laser transitions into a crisp, non-tactile cutting instrument with immediate margin hemostasis. Despite emerging fiber lasers, the carbon dioxide laser remains standard for a transoral laser microsurgery. For laryngeal benign lesions, leukoplakia, or early clotic carcinoma. The primary advantage of the carbon dioxide laser is its precise vaporization profile, because its chromophore, as I said before, is water. Cellular water absorbs the energy within a 30 micrometers depth. The zone of adjacent thermal edema is minimal. We have delivery systems to use such as lasers. Some has articulated arms and some has fiber optic cables. Mirror lens system we can use, hollow waveguides, micro manipulators, especially for carbon dioxide laser, and robotic scanner. Articulated arms with micro manipulators mounted onto the operating microscope, utilizing joystick control and robotic line scanners to deliver precise microslides.
Yeah.
Flexible optic cables or flexible hollow waveguide guides, allowing us non-line of sight fiber-like handpiece delivery into challenging anterior commissure, unfortunately, anterior commissure anatomical sites. Laser safety in the operating theater is paramount. According to international safety standards, we have 4 types of lasers. All surgical lasers are class 4 types. As all of we know, education is the most important part of our safety considerations. We have to develop our colleagues, anesthesia team, and nurses knowledge about laser use in the operating theater, and we should be we should review our complications with the colleagues in a periodic timeline. Laser safety in the operating, every individual inside operating theater must be wear wavelength specific protective eyewear equipment. Optical density ratings must match the active wavelengths. Patient's eye must be lubricated and protected with the wet eye pads and gauze. Laser tissue vaporization generates a biohazardous plume containing carbon particles, toxic gases, and viral particles. Especially for HPV, it is so dangerous. Dedicated high-efficiency particulate air plum evacuator must be held within 1 centimeter of surgical area. The most catastrophic complication of laser surgery is airway fire. An airway fire requires 3 components: fuel, endotracheal tube, oxidizer, oxygen, and ignition source, our laser beam. Laser saves, to eliminate this hazard, strict anesthetic protocols must be enforced. Standard polyvinyl chloride tubes ignite rapidly and must never be used. Instead, surgeons must utilize specialized metallic spiral tubes or laser-resistant foil-wrapped tubes. The double cuff of the laser must be inflated with sterile isotonic saline tinted with methylene blue. If a stray beam strikes the cuff, we have to be careful, because this means we strike the cuff and the methylene blue fluid goes through the airway. The anesthesia team must keep inspired oxygen concentration, PO2, at below the 30% and avoid nitrous oxide completely from the system, from the anesthesia system. Exposed portions of the tube subglutically must be covered with wet gauzes or saline-soaked catenoid patties. If a fire occurs, if an airway fire occurs, immediately we have to stop laser firing, discontinue ventilation, and disconnect the system. Instill saline into the airway, extinguish and remove the endotracheal tube, re-establish ventilation via laryngeal mask or tracheotomy, perform rigid tracheobronchoscopy to clean the debris and to inspect the airway patency. We have general safety rules. We have to keep lasers in standby mode when not in operation. Bystanders should remain at a safe distance. Warning signs and LACTARs should be ready in the operating theater. We have to wear protective glasses. Never use the laser as a pointer to a coworker or to an instrument. We don't aim the beam at flammable materials, and we have to be informed to check our system in the surgery. In summary, we use laser in laryngology as a cutting device. Resurfacing for mucosal resurfacing. It has pro-inflammatory and vasoconstriction effect. We can use laser in both benign and malign pathologies, and all three subspecialty of laryngology could use this device for their surgeries. I'd like to mention about oncological milestones with the laser use. Extensive clinical trial data demonstrate that primary transoral laser microsurgery achieves oncological outcomes equivalent to definite radiotherapy, while offering distinct therapeutic advantages. 5-year overall survival exceeds 95% in T1 galactic carcinoma. Local control and disease-free survival is comparable between transoral laser microsurgery and radiation therapy. Ultimate laryngeal preservation rates range from 90% to 98% with laser. Transoral laser surgery is a single-stage, cost-effective procedure with minimal hospital stay. Crucially, it preserves radiotherapy as a full therapeutic reserve option in the event of local recurrence and second primary head and neck malignancies. Thank you so much for listening me for the first part of my presentation.
Dr.
Yes.
Baik, Dr.
Dr.
mohon maaf, dokter masih dalam keadaan mute.
Okay. Thank you very much for Professor Mehmet for this excellent and insightful presentation. And feel free to raise questions from the raise hand features. Is there any questions? Okay. So maybe
I will give you some tips about blue laser or carbon dioxide laser.
Yeah.
I'm currently using laser systems in my laryngology experience for 6 or 7 years. In the beginning, I used carbon dioxide laser with joystick, micro manipulator, and this kind of devices are so large to locate in the operating theater. But blue laser systems are so small compared with carbon dioxide laser, and you cannot have any problem with the surgical site restrictions. You can use it in the office-based procedures very easily via flexible laryngoscope, nasopharyngoscope, and for the last 3 years, I didn't use any carbon dioxide laser system in my operations. Every time, I always used blue laser system in my laryngological procedures. In my opinion, they have better results in benign laryngeal lesions because its hemostatic effect is much more better than the other laser types. These are my considerations about blue laser. We have one question, Dr. Indra. How about your experience in
Hypopharynx.
Hypopharyngeal?
Yeah.
I have never experienced any laser using in hypopharyngeal carcinoma because for hypopharyngeal carcinoma we always perform open surgeries, partial hypopharyngectomy, or as you know, total laryngectomy and hypopharyngectomy. I have never used in hypopharyngeal carcinoma.
So, okay. Any questions again? Okay. From Santo Muda Pratomo.
Yes, Dr. Santo. Is there any experience
using blue laser for laryngeal stenosis?
Yes, laryngeal. Yes, I used blue laser in my airway cases, especially subglottic stenosis or glottic stenosis web lesions, web-like lesions. I want to answer the last question, Dr. Indra. I used blue laser for cricopharyngeal myotomy, and its effect is good. I recommend you can use the blue laser in cricopharyngeal myotomy for the dysphagia patients. And Dr. Santos' question, I will give you some examples in the second part of my presentation. Yes, I use blue laser for my airway cases. If you have a web-like lesion in glottic segment or tracheal segment or subglottic segment, you can use very easily. Maybe you can use in office because it will go through the flexible laryngoscope, and you can easily cut the web-like lesion in the office with this laser system, especially in glottic lesions, laryngeal stenosis.
And Dr. Buali Mustafa.
Safe power.
What is the safe power for section, for cutting maybe?
It depends on the lesion, because sometimes for the glottic carcinoma lesions, you have to use more power. I'm currently using continuous mode 10 watts for carcinoma, for chordectomy, for the carcinoma patients, but in pulse mode and 3 or 4 watts, I can use this kind of system, 3 or 4 watts and pulse mode. For the benign lesions, especially has enhanced varices or enhanced vasculature lesions, especially in hemorrhagic polyps. Blue laser is very useful because, as I said before, it uses chromophores. It uses oxyhemoglobin as a chromophore. So, if a benign lesion has enlarged vessel adjacent to the lesion, you have to use blue laser very easily and reliably. Is it efficient? Yes. Is it efficient? Yes, please.
Dr. Mustafa asking again about the stenosis. Do you need stenting after the blue laser? And he asked again about the efficient. Is it efficient for the papillomatosis, the RPP?
I would like to answer the last question. Yes, it's very efficient in laryngeal papilloma. There is no difference between carbon dioxide laser and blue laser for the laryngeal papilloma because you have to vaporize the lesions. Yes, we know carbon dioxide lasers vaporize better than blue laser. However, its vaporization effect, it's not bad. I can say this for blue laser, and you can use in laryngeal papilloma the blue laser. I don't use stent in my airway cases. If there is a web-like lesion, you can use blue laser, and you can use after blue laser a balloon dilation. But if you have granulation tissue, hard granulation tissue, not web-like lesion, in my opinion, we have to perform open surgeries, open airway surgeries. Yes, you can use blue laser in airway lesions, like web-like lesions, but I cannot, I didn't replace a stent after the blue laser.
Okay, so if the laryngeal papilloma occupied the anterior commissure, do you have tips for that?
We use blue laser without a joystick. So we can use delivery systems like aspirator, surgical aspirator, or fiber optic cable. So anterior commissure is a hard anatomical site for cutting with the blue laser. Yes, I know, but with the time, I gain much more experience by using blue laser in the anterior commissure lesions. What do I do? What did I do? I made one surgical aspirator with the angle. Slight angle at the tip of the aspirator. We make a slight angle, and by this angle, we reach the anterior commissure very easily. But if you use direct aspirator to reach the anterior commissure for the blue laser, you may have some problems. Maybe this is a practical tip for you. This will be a practical tip for you. make slight angle at the tip of the aspirator or fiber optic cable. This creates a better approaching experience for me. Reaching is easy with this movement.
Okay, thank you. And from Indra again, if metal ET tube not available, is it safe enough to use non-kinking ET tube with gauze?
Yes, closing the tube in the surgical at the surgical site with the wet gauze is very easily and reliably. You can rely on the wet gauze to close the tube and the cuff.
Okay. 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 Is there any questions again? Okay. I think that's
one more. In laser surgeries, I always talk with the anesthesia team online. Live on the surgery, because sometimes you have to cut the laser system, and when you cut the laser system for a break or something else, I don't know, the anesthesia team opens oxygen for 100%, but when you use laser in the surgery, they have to close oxygen and they have to give the patient air room, because air room has 21, as you know, 21% oxygen.
Yeah.
And when we use laser, the oxygen level is has to be below the 30%.
Okay.
Always talk with the anesthesia team.
Okay. So I will repeat again. Always talk to anesthesia to put the oxygen with the fraction 21%. Never more than that. Okay. Is it to prevent the airway fire?
I have never experienced airway fire, and I don't want to experience. It's so, maybe it's worse than some cancers. I don't know, because the patient's airway patency is blocked and diminished. It's so catastrophic. I have never experienced.
I have once. I have
I'm
once.
sorry.
Yeah.
I'm sorry for you. I'm sorry
Yeah.
for you.
It was a stenosis, the granulation tissue at the trachea, and we did the intubation from the stoma, and after that we did the laser with the granulation tissue under the stoma, so the oxygen is help with the ET tube from the stoma. But I already said, please do the oxygen in a 21 fraction. Fraction is 21%, but I don't know. Suddenly it.
Yes.
Yeah.
Of course.
Hopefully the patient is alive. Okay.
The airway fire always has a potential to be. We know this, but the surgeons have to be very careful. In every step in laryngeal surgery with laser, we have to be careful, and we have to be open-minded for the dangers.
Okay, so we're gonna move to Turkey clinical case video and explanation by Professor Mehmet.
I'm going to present my second part of my presentation. In the second part, I will show you some laser surgeries in laryngology. In this slides, you will see blue laser surgeries and carbon dioxide surgeries. For the first video, as you can see, we performed a total arytenoidectomy, and we used carbon dioxide laser in the surgery. Firstly, we excise, we cut the mucosa above the arytenoid cartilage, and we use cuneiform cartilage and corniculate cartilage site to reach the arytenoid cartilage muscular process. We don't have to excise the mucosa, because if we excise and get out from the larynx this mucosa, healing process will be longer, and synechia may occur. Sorry, synechia may occur. So we cut but not excise, as you can see. Below the corniculate and cuneiform cartilage, we find cartilage muscular process. Yes. I'm so sorry. I'm so sorry. I'd like to open it again. We found the arytenoid cartilage, and we dissect it from the adjacent tissues. We have to be careful about the posterior laryngeal artery, because it's located near the lateral side of arytenoid cartilage, posterior lateral side of arytenoid cartilage. As you can see, arytenoid cartilage was removed, and we have a airway, enlarged airway. Finally, this tissue is inflammation tissue, granulation tissue, but not going inside the airway. So yes, we use carbon dioxide laser, and this picture is from the first week of the patient after the surgery. My second case is also total arytenoidectomy case. I used blue laser in this surgery. This is the early postoperative surgical field picture video. I'm sorry. You can see there is no difference. There is no difference between carbon dioxide laser and blue laser scar tissue. It's so effective. These pictures, you can see chordotomy before and after pictures. I use carbon dioxide laser for this case. As you can see, we cut through the vocal fold just anterior part of the vocal process of arytenoid cartilage, and we cut this cord, vocal cord, through the inner perichondrium of thyroid cartilage. In this video, you can see the chordotomy case, posterior chordotomy case, and I use carbon dioxide laser. As you can see, I replaced the wet cotton to close the endotracheal tube. As you can see, there are plume and vaporization may occur. You have to suck. You have to use suction devices. This is the final appearance of the thoracic area. This patient has bilateral vocal fold paralysis. Also, a chordotomy case with posterior chordotomy case with ventriculotomy. Firstly, I excite the ventricle, band ventricle mucosa and submucosa to enlarge the thoracic area. And after, I excite the vocal fold mucosa, just anterior part of the vocal process of arytenoid. The final appearance, as you can see. Now, I'm going to show you a chordectomy case. Sorry. We have a cauliflower-like lesion, anterior part of the left vocal fold. After the surgery, after the excision, after the chordectomy, there is no hemorrhage, there is no char. I used blue laser in this case. Remove the mucosa and submucosa through the subglottic mucosa. As you can see, we performed left chordectomy, anterior commiserectomy with the blue laser, and anterior chordectomy of right vocal fold. Another carcinoma, glottic carcinoma patient. As you can see, I used blue laser with an aspirator. This aspirator aspirates the vapor and plume. Also made a template for us to use blue laser fiber optic cable. When you shoot the blue laser, the light emits in the blue spectrum. as you can see. It has precise cutting edges without hemorrhage, but you have to use blue laser with a template. As you can see, there is a chordectomy case. I used carbon dioxide laser for this case. Did you see the char?
Yeah.
Did you see the carbon particles and char?
Yeah.
Yes. Maybe, in my opinion, the most advantageous part of carbon dioxide laser is you can use carbon dioxide laser with joystick without any template. But blue laser is more efficient in office procedures. I want to show you the washing by saline. Because the temperature begins to rise, you don't have any device to cool down the laryngeal tissue except saline. And maybe, I'm sorry, you saw here, you can see here a wet gauze, neurosurgical catenoid patties I am using currently to block the tube and cup. There is a case, example case for the Ranke edema and vocal polyp. I used carbon dioxide laser for this case. Excise the mucosa without harming the ligament, vocal ligament. There is a subglottic stenosis case. The stenotic segment is web-like, so you can easily use laser to incise the web, and after incising, balloon dilation. I used here carbon dioxide laser, but you can use blue laser as efficient as carbon dioxide laser. By the way, I have experienced a little problem with carbon dioxide laser in the long airway systems, because if the lesion or granulation tissue locates distal part of the airway, your light beam cannot be reached to the granulation tissue or lesion. But your blue laser template, if you make longer template, you can use blue laser very reliably in the distal part lesions, airway distal part of distal airway lesions. As you can see, we incise the web. I used wet cotton, wet patties. The patient has tracheotomy. I inject steroid to the lesion. This is a Mercedes incision, as you can see. And after I dilate the lesion with the balloon. Yes. There's a tracheal stenosis patient. In 2016 and 2018, I used laser surgical systems to make airway to perform airway surgeries, endoscopically airway surgeries. However, after 2019, I quit this kind of surgeries, especially in tracheal stenosis cases. But I want to show you one of my cases. As you can see, carbon dioxide laser power is reduced by the vertical length, because distal part lesions, in the distal part lesions, you cannot create a powerful light beam with the carbon dioxide laser. Its power reduces with the length. There's a vocal stripping case with the laser. As you can see, I used carbon dioxide laser. However, I prefer blue laser recently because its hemostatic effect is much more better than carbon dioxide laser, and this kind of lesions have big vessels around them. So blue laser is much more reliable, in my opinion, in the dysplastic lesions of larynx. Dysplastic lesions of larynx. Because every dysplastic lesion of larynx have large vessels around them. Now, I want to show you one of my cases, which is a voice feminization surgery. I sutured the vocal folds, anterior parts, membranous parts, as Wendler demonstrated. As you know, Wendler surgery. After Wendler, as you can see, I use blue laser to perform laser glottoplasty. 3 or 4 watts. In 3 or 4 watts, you can use blue laser with the pulsed mode to make stiff mucosa and stiff mucosa. Why we want to make stiff mucosa or submucosa for the voice feminization surgeries? Because stiffened vocal folds creates more high-pitched voice, feminine voice. And I use blue laser with a template, as you can see, a template of aspirator, surgical aspirator, surgical laryngological aspirator. This is the before picture, first picture of the patient, and this is the second postoperative picture of patient, voice feminization patient. As you can see, there are little char and burn sites of vocal folds of mucosa and submucosa. But this procedure makes vocal fold stiffness much more, and we have more high-pitched voice by this procedure, laser glottoplasty.
What is the setting of the blue laser?
Yes. I use blue laser in the surgery.
I mean the setting. For what? For what? The setting.
Yes. 3 or 4 watts. I'm so sorry. Yes, 3 or 4 watts is efficient. There is no need to increase the watt for these cases, because we don't want to excite. We only want resurfacing. Want to make resurfacing. We only want to make resurfacing. And my last case is laryngeal papillomatosis. I used carbon dioxide lasers to burn the papillomas, but only resurfacing mode. 2, 3 or 4 watts of blue laser is efficient, is enough. There is no need to increase the watt to the 10 or 9 watts, because they are because we are using this kind of watts for the excising, for the ectomies. As you can see, there is no papilloma of the left vocal fold after the surgery. Thank you so much.
Thank you. A very nice presentation and the video and the explanation, of course. And there's questions. Do you think that the manipulation of the laser fiber is very difficult and the imprecise inside the laser because of the length?
I have to be honest. In the beginning, yes, it's difficult. But after the 10th case or 5th case, I don't have any difficulty. I didn't experience any difficulty by using blue laser for my cases. And as I said before, it is so light, it is so small to use in the operating room and the office. But the carbon dioxide laser is much larger device for the operating room, and we easily found blue laser rather than carbon dioxide laser in our private practices.
Or do you have any option for the laryngoscope? You use a Dido or laryngoscope, the clean sizer or commissura anterior?
Yes. Classical clean sizer, G-type clean sizer. I use Virda laryngoscope of Sp.T.H.T.B.K.L. As you know, there are 2 buttons to open vertically, and for the anterior commissure part, I have to be honest. In the beginning, it's difficult, but after, you don't have any difficulty with the blue laser.
Okay. So, because no other questions, I have no opportunity to give experience of mine. So I will show you the video. The committee, can you share the... Oh.
Sorry, Dr. Dijan has a question.
Oh, yeah?
What is the best way to secure the airway? Endotracheal, you have to use endotracheal tube to perform the surgery. What is the best way to secure the airway? What I said in my presentation are the best ways, the whole package. You have to inflate the cuff with the saline. You have to cover the cuff and cover the tube body with the wet gauze or neurosurgical catenoid patties. You have to be careful regarding oxygen levels. You have to warn your anesthesia team when you open the laser, when you close the laser. These are whole package for the securing airway. Laryngeal mask airway can be used? I don't think so. Endotracheal tube you have to use, but one time it's not a good thing. Yes, I said, but I will say to you, but it's not a good thing. One time I used blue laser with jet ventilation. When the jet ventilation is open, I didn't use laser. Stop the laser. The anesthesia gives 100% oxygen to the patient to increase saturation level to the 99 or 100 to fill the lungs with the oxygen. After this procedure, the filling the lungs with the oxygen, I have 2 minutes to use laser in apneic anesthesia. There is no oxygen. There is apneic type anesthesia. I have 2 minutes to use blue laser or carbon dioxide laser. But after 2 minutes or when the anesthesia demands, I will stop the laser and I will give the patient to the anesthesia team to fill the lungs with 100% oxygen. I have experienced this kind of surgery. One time, I didn't have any problem. I didn't get any other problems for the other systems, cardiac or respiratory system. Yes, it's a good surgery, very comfortable surgery because there is no tube, there is no patty, there is no cotton. Okay, but in the surgery, I feel very uncomfortable, and I have to be careful. I have to talk. I had to be careful in the surgery. I always talked with the anesthesia. Stop. Give oxygen. What is the saturation level? Etc.
And in case of you do the malignant case, did you do a free margin with blue laser?
Yes.
Yeah.
Yes. In every laryngeal glottic carcinoma cases, we use frozen pathologies as as yours. Classical defining of chordectomy is essential for us. We incise the borders of the carcinoma, of the lesions, and after we excise the lesions. Following excision, we send our margins, our frozen pathologies to the pathologist intraoperative.
So we can use it in blue laser, right?
Yes, of course. Yes, of course.
Okay. So we're gonna move, if there's no questions, we're gonna move to Indonesian cases. Share. Okay, this is a case of boy 2 old month with a previous complaint shortness of breath, and patient first underwent tracheostomy. We can see from this video there's a smooth mass pushing the epiglottis through and obstruct the airway. So the patient have a retraction, the epigastrium retraction and the suprasternal retraction. And sometimes the patient looks cyanosis. Sorry. After we aspirate the cyst, I think the mass with the smooth surface is a cyst, and then we aspirate the cyst to decrease the size, and then we make with a blue laser with a wand, we make a circular motion of the mass, and the mass wall is quite thick, and we did in a cutting, so the setting is 4 watts and 500 on and 50 off. It's not easy. Sorry. But after all, it can release, the blue laser can release it, and then we burn the depth with the blue laser. And the post-operative, we can see that the mass is already gone, but the patient still have laryngomalacia type 2, but it doesn't affect the airway. And another cases of follicular cyst, it mimicking laryngomalacia type 3, and because of this mass, we just cut the mass with the blue laser. You can see that the inside there's a thick liquid, and we remove the mass with the blue laser. The same with the circular cut. And it has a very nice cutting, and this 5 years old with history of glottic and congenital trachea stenosis, catenaire 2, it's blocked about 60%. patient already on T-tube but never came for a regular in the past visiting in a regular in the past 2 years, and come again with examination of there's a mass inside the trachea, I think in a subglottic, with the pedunculated granulation tissue, and with blue laser still with the wand we can remove it step by step, and this is the result. Yeah, the pedunculated granulation tissue is on the left side, and we inject the steroid after that. And another case is the girl with the hoarseness and shortness of breath came to the emergency care for the examination. We seen the laryngeal papilloma occupying the vocal cord. And then we use the blue laser again. As you know, Professor Mehmet, we don't have CO2 laser here. So blue laser is the tools that help us a lot here. We can see the anterior commissure already involved, and luckily there's no synechia in the anterior commissure after the blue laser. It seems like it has a synechia, but after that the patient come again to the outpatient clinics, and then the patient can speak well.
Ini banyak. Iya tadi. Aku ikan. Tadi jadikan? Iya. Di mana? Ini.
Okay, thank you. That's all about my questions. It's about pediatric cases, and you can raise questions here. Is there any questions? So I have a question for you, Professor. Did you use stitch to the mucosa left after you remove the arytenoid?
Yes, this technique is called by Z-P.L.F. Yes, I stitched the medial mucosa of arytenoid cartilage to the lateral part of larynx.
Okay, okay. Yeah.
Open mucosal healing is not better, so we have to close as much as we do.
Okay. Actually, the partial arytenoid is we remove the focal process actually, but you remove the muscular process, right?
Yes. For the total arytenoidectomy cases, yes, I remove all of the arytenoid cartilage and suture the medial mucosa to the lateral side of larynx. However, for the partial arytenoidectomy cases, I didn't suture the mucosa.
Okay, only remove the focal process only.
Yes, focal process, yes.
Okay. Okay, I think there is one questions. Oh, no, it's from the STI. So so the clean size, the laryngoscope itself have a benefit for we do the technique, because if the laryngoscope is narrow, we cannot do the technique well, right? Yeah. So what kind of laryngoscope did you use a lot?
Klein sizer.
Oh, klein sizer.
G-type Klein sizer.
Oh, Z-type klein sizer.
I'm generally using Klein sizer G-type laryngoscope.
Did you do with a Dido with a wide angle for the?
No. Yeah. Yes, of course, I did. However, I don't want to prefer, because wide angle, I'm not so sure about the anterior commissure and the membranous port of vocal folds. So wide angle laryngoscopes, I don't want to prefer.
Okay.
I want the narrow angle laryngoscope to reach the anterior commissure easily.
Okay.
Great and good exposure for the anterior commissure.
Okay. If there is no questions,
there is one.
There's one.
Yes. Do you have experience using hyaluronic acid based spray to prevent snakia? I don't know. Hyaluronic acid could be used, maybe used in preventing snakia. I used cortisone sprays, steroid sprays, to prevent snakia or stenosis after laser surgery, but I didn't use hyaluronic acid. I haven't used before.
Okay. So you never use the hyaluronic acid. It's only for augmentation.
Yes.
Yeah.
Yes. Augmentation, injection laryngoplasty, yes.
Yeah.
However, for this preventing snakia, I didn't use.
You use corticosteroid only, yeah? Or you use corticosteroid only?
Yes.
Yeah.
Yes.
How about mitomycin? How about mitomycin?
In Turkey, we don't have mitomycin.
Oh, in Turkey, you don't have mitomycin.
We don't have mitomycin.
Okay. Yeah.
I don't know why, but we don't have in Turkey.
Okay. We still have time for the questions. Do you have any questions? You can raise hand, or Indra, you can raise hand, or put it in the chat applications. Okay. So, do you have a take-home message for this?
Yes, I. We discussed it with Fiola and Jessica. Fiola and Maya yesterday. You can rely on blue laser as carbon dioxide laser, and if you have never experienced or performed laser surgery before, it's time to start this kind of surgeries as soon as possible, because laser is much more hemostatic and precise rather than past and rather than cold instruments. That's all. If you prefer for benign lesions, if you want to perform any laryngeal surgery for the benign lesions, you can prefer blue laser reliably. You can rely on the blue laser, especially for the benign lesions, large vessel lesions, microvasculature, varices. It's so efficient in this kind of lesions.
And for me, the blue laser exhibit a good coagulations, vaporization, and bloodless surgery. And
Yes.
that supplies the successful for pediatric airway.
Yes.
Okay. I give to the MC.
Okay. Thank you very much for Professor Mehmet and Dr. Ezi. Thank you for sharing such valuable clinical experiences with us today. Okay, Bapak dan Ibu Dokter, we have now come to the final part of our webinar. Before we move to our group photo, we kindly ask all participants to take a moment to complete the polling that will appear on your Zoom screen. For our international participants, the polling will also appear on your Zoom screen, and please take a moment to submit your response. Your participation is very valuable to us and will help us understand your feedback regarding today's scientific session. Please take a moment to complete the poll before we continue to our group photo. Okay, doctors, we have 2 polling questions here. Okay, please open the chat room and click the Slido app. And we start the first question. I will wait for 1 minute. We only have 2 polling questions here, so please, doctor, answer the polling question. Okay, I think enough for the first question, and we can continue to the second question. Okay, the second question already appear on your screen. Please answer the question. Okay, I think enough. Okay. This is the last question, the second question. Okay, I think enough. And thank you very much for your participation, doctors. And now, before we officially close today's webinar, we would like to invite everyone to join us for a group photo. For those who are able to, please turn on your cameras and stay with us for a moment. Jessica will guide this session.
Okay, doctor. I will screenshot the first page. 1, 2, 3. Okay, the second page. 1, 2, 3. The last page. 1, 2, 3. Udah pada bubak nih kan? Okay, thank you.
Something. Oh yes.
Okay, the photo session already done. And for all doctors, we have now reached the end of today's webinar. It has been a great pleasure for us, PT Sometech Indonesia, to have you all with us this afternoon. On behalf of PT Sometech Indonesia, I would like to express our sincere gratitude to our distinguished speakers, Association Professor Mehmet Burak MD FEBORL-HNS, and Dr. Fauziah Fardizza Sp.T.H.T.B.K.L Subspecialist Laryng Konsulen. Thank you for sharing your clinical knowledge, experiences, and real-world cases with all of us today. Dr. Mehmet, thank you very much for joining us from Turkey and sharing your international clinical experience with our participants. And Dr. Ezi, thank you for sharing your local clinical experience, guiding the discussion and bringing both perspective together throughout today's session. Dan untuk dokter-dokter semua, hari ini kita mendapatkan kesempatan untuk melihat penggunaan blue laser dari dua perspektif klinis, yaitu international experience dari Turki dan pengalaman klinis dari Indonesia. We hope that today's presentation, case discussion, and exchange of experiences have provided useful knowledge and new perspective for your clinical practice. We would also like to thank all of our doctors and participants, including our international participants, for taking the time to joining us today. Your participation and engagement have made today's webinar a valuable scientific discussion. Once again, thank you very much to all our speakers, moderator, guests, and participants. I am Viola, product specialist from PT Sometech Indonesia, and it has been my pleasure to be your host this afternoon. Thank you for joining us. Stay healthy, keep learning, and we look forward to seeing you at our next scientific event. Wassalamualaikum warahmatullahi wabarakatuh. Thank you, everyone, and have a wonderful afternoon. See you at our next scientific event. Bye-bye.
Thank you so much.
Thank you.
Thank you so much, Professor.
Best wishes from Turkey to Indonesia. It's great honor to meet you and to talk with you. Thank you so much.
We're gonna meet on next year on APLA.
I hope so. I hope so.
Okay. Bye.
Bye.
Thank you.
Apa sih? Taksi. Ya, lebih cepat 20 yang. Ya, soalnya nggak ada yang nanya. Cepet deh nanya.
Terima kasih, Dr. Ezi. Terima
Oh,
kasih,
ya.
dokter semuanya.
Oke, bye Viola.
Bye, dokter.
Mana nih?
Terima kasih dokter.
Ya. Live.